patience and doing all that is required to save hair, as we will see from the presentation. So thank you very much, NAD, once again, because I did learn a lot and added to what I know in the in giving this lecture, in preparing for this lecture. Okay, so this is my outline, and I will just be dealing with the topic based on the introduction, a little bit about the hair biology, which will enable our understanding of the topic in question, and then the causes of hair loss, and then a framework for how we would evaluate hair loss. And then I'll start rounding up with the common types of hair loss in our climate, and then conclude. Well, as a means of introduction, hair loss is a common thing. Virtually everybody or knows somebody that has a problem with the hair. And so it affects people worldwide.
Oh, that's a freak. You know, fine as it be now.
Hello, can you hear me? Hello.
Yes, ma'am. Can
you? Because there's some interference. So there are various causes of hair loss, and there are different types. And there's a limited way of. I'm sorry, but please, I'm being there's interference, and it's I can.
Professor Henshaw, hold on a minute. Hawa, please, can you mute everybody else? Okay, please go ahead.
Okay, thank you. So like I said, there are various causes of hair loss. There are different types of hair loss, which is also called alopecia. But there's a limited way the hair will manifest clinically. That hair loss will manifest clinically. And that's by hair loss. It could be the thin hair, the shaft breaking of hair, or it could be a total loss of the hair. And then I might add that hair loss, there are some types of hair loss, alopecia, that is peculiar to the African person or the Black person, whichever you choose. And this is because of the nature of the Afro-textured hair. It's very fragile for certain reasons, which we'll see, and it makes it a lot more vulnerable to loss. And in a particular person, there might be more than one type of hair loss occurring at a time. And this is important, particularly for treatment, because you might treat one and you might be successful, yet there is still hair loss. And so it's important that evaluation is effective. It is a distressing condition that significantly impacts the quality of life. And the diagnosis can be challenging, as, you know, like I said, you can have more than one type of hair loss existing at a time. And then the standard tool which we use to evaluate hair loss that enables us find the differences is sometimes the criteria sometimes does not apply when it comes to the African hair. And so having an effective evaluation framework actually helps with treatment, and prompt intervention by a dermatologist who is trained to see to hair loss or to treat hair loss is very important, because time is hair follicle. Now, the hair follicle is a specialized structure. Some people would like to call it a mini organ, which is a structure of the epidermis that projects into the dermis. For those who are not medical people, the epidermis is the topmost layer of the skin. So the hair follicle, which actually produces the shaft that we see, comes from the topmost layer, but it deepens, it projects downward into the dermis. Like I said, it is thought to be a mini organ on its own because it actually has a self-renewing capacity, and it can be independent, and it's capable of independent growth and regeneration. It's broadly divided into what is seen, that's the hair shaft, what people see as hair, which is actually dead cells. It lacks sensation, so you can do with it whatever you like. But then deeper under, beneath the iceberg, like the hair shaft is like the tip of the iceberg, but beneath the iceberg is the hair root, which is embedded inside the skin. And this is a living, vibrant organ. Like I said, has cells that can regenerate itself. The root expands distally into the hair bulb. That's the hair root. This other part goes down and forms the hair bulb. And in this hair bulb, we have what we call the hair matrix. The matrix is a layer of actively dividing cells, which can divide and differentiate to form the various hair layers. The outer root sheet, we can see the diagram, the outer root sheet, the inner root sheet, and other things. And then we have other added things to the follicle, like the sebaceous gland that actually produces sebum, a lubricant, is some sort of a conditioner for the growing hair. And then the erector pili muscle, which actually helps for in certain things, like trapping air when one is cold, trapping air to cause some insulation and warm us up, in addition to other things. Now, the hair has a cycle. Let me state here that the adult hair follicle is complete. No new follicles are being formed. So that implies that we must be careful with the hair follicle. Do not lose it. Don't lose it in such a way that it cannot regenerate, because there comes a time when the hair follicle cannot regenerate. So the cycle has the growing phase, the anagen, which lasts 2 to 7 years, the catagen, which is just for a few weeks, and then the resting phase, which lasts for 2 to 4 months, and then the cycle repeats with the new hair forming anagen, and that hair lasts for about 2 to 7 weeks. So now, the function of the hair, you can see the various functions. It subserves a wide range of functions. It protects us environmentally. It is said that the hair is actually is more sensitive because of the innervation of the hair from the dermis, from the lower portion of the skin, the dermal papilla, which is underneath the bulb. The bulb surrounds it, where the hair gets its oxygen and its nutrients from. It also has nerves that actually protect us. So something as little insects can be detected by the hair follicles, and it reacts. So it actually helps in safeguarding the skin from noxious elements. Temperature regulation, I talked about the erector pili muscle trapping air and causing insulation during cold. Sensory enhancements, stem cell reservoir, that's the matrix which produces the cells that keep regenerating. And then we have racial, it actually forms racial identity, it's a sociocultural function. You know that I'm a Black African by the type of hair I have. Social identity, physical attraction, and many other such functions, even spiritual. Remember, in the Bible, there were times when God would say he would use baldness. Instead of braiding of hair, they would have baldness. So that was a form, it was seen as a form of punishment, and it's seen same. There are people who have dreadlocks from birth, and it's like, don't cut it, because there's a spiritual connotation to it. So the hair subserves quite a lot of value functions, and then particularly the psychological function, the self-esteem and confidence that, particularly for women, a woman has when she has her full mane of hair all right? An emotional signaling, I don't feel too good today. I can decide, oh, this is a period, I'm not feeling too happy. I'm going to cut off my hair. I'm going to do this to my hair. So there are different things that the hair serves, different functions. Now, the African hair, the Asian hair, and the Caucasian hair, they are different. And both the fiber, the ostia, that's the hole in which the hair follicle comes out, that's the shape of the follicle. It's oval and oblique or S-shaped, as it's usually said. That's twisted. Sorry. So the hair shape is twisted. The density compared to the other races, the African hair density is lowest. It has a thinner, each shaft has a thinner diameter, and it's really kinky and curled. So for a short hair, someone who has short hair, you can drag it because it is so tightly curled. And this in its own, it's because of the disulfide bonds. And this can break. That's why there's increased fragility. Although it has the highest lipid content, it has a lower strength. That's the ability to withstand tension. And then hydration too is low. So it can easily be damaged. I was saying, although it has a high lipid content, I had talked about the sebaceous gland producing sebum to condition the hair. But then because of the shape of the hair follicle, it's a bit difficult for it to be, passed on, to be secreted to the hair follicle, to rise up from where it is inserted on the hair follicle. So these disparities make the Afro-textured hair drier, more liable to breakage, right? And has very low tensile strength. So there are myriad causes of hair loss. We have the dermatological causes, not just the hair. There are things like your seborrheic dermatitis and tinea and all other things. You have infectious diseases like syphilis, may lead to hair loss. Internal organ diseases in the liver, in the lungs can lead to hair loss. Cancers, some autoimmune diseases, endocrine diseases, malnutrition, some drugs, and stress, psychological states can actually lead to hair loss. So the causes of hair loss are myriad, and they don't always have a specific way they present. So you can have different causes, but presenting the same way. Like I had said, there are limited ways of manifestation of hair loss. And so you need an expert to be able to look beyond what is seen and tell what exactly might be the cause of the hair loss. Now, in evaluation, I just created like 4 steps for the evaluation of hair loss. You have the patient history where you're trying to find out when a patient comes to you, you want to know the onset. When did it start? How long has it been there? How does it look? Where did it start from? Did it start from the front of the hair, or did it start from the crown of the hair? That's the vertex of the hair. Do you have a family history of hair loss? Maybe your father has what we call the usual baldness, or we call androgenetic alopecia, or even your mother. Your hairstyling, do you perm your hair? Is your hair anything? Do you straighten your hair? Do you use a lot of wigs? Are you always braiding? Those are important things to ask. And the drugs the person is taking, some people are on a diet, and some types of diet can actually lead to diet crash, can actually lead to hair loss. Is there sickness? Is a person who has a heavy menstrual flow who's been having a heavy menstrual flow and is more or less constantly anemic might be losing her hair and is wondering, it could just be due to iron deficiency, anemia, or do you have thyroid problems, even diabetes mellitus. And then you go to the physical examination. This is when the doctor looks at it and is trying to find out the distribution. Is it at the margins? Is it a focal thing in localized to certain areas, or is it diffuse? There's scalp signs, are there, signs, papules, like signs of inflammation, scales, or darkening of the patch, or, boggy-like nature on the past? Is there pain or tenderness? Okay. For the history too, you're talking about itching and added symptoms that could be there. And then what's the texture? Does it break easily? There are certain things, the pull test, where you try to see if it's breaking easily. There's signs of scarring on the hair. It could be shiny most times, but not always. The hair that is scarred, when the hair is scarred, it cannot regenerate. It could be shiny, so you know what you might be dealing with. And then the use of trichoscopy. Now, please, it has to be adapted for the Afro-textured hair. Remember, the honeycomb pattern is normal in trichoscopy to the African hair. The white dots, too, that's the acrosyringium or the follicular dots, they are also normal. So there are a lot of times we see, and we're talking about white dots in certain types of alopecia seen with the trichoscopy. So we must adapt the criteria when we are looking at the African hair. Peripylar pads might not be easily seen. The peripylar halos might not be easily seen because of the pigmentation of the African scalp. So you might want to look for CAS, look for the units, follicular unit density in each field of view, and then look for empty or follicles or follicular dropout, which signifies scarring. And then investigations, like I talked about, iron deficiency, vitamin D deficiency, the thyroid panel, hormonal screening for, polycystic ovarian syndrome. And then, not always, but there are certain types of hair loss that might require a scalp biopsy. We don't do biopsies often, but there are times that you might need to do a hair biopsy. Now, going to the types of hair loss, we have the non-cicatricial, which is the non-scarring type of hair loss. They don't not usually scar, but when it is prolonged, there is a common end game to it, which is scarring for some of them, like the traction alopecia, which is one of the most common types of alopecia in Black people. Okay, that's because of the hair, the way we manage our hairstyles, the hairstyles that we love so much. Of course, they've got to be tight for them to look. You have to pick up all the hair for it to look beautiful. It is a cause of hair loss. And then the telogen effluvium. I'll just quickly talk about this because I won't talk about them in details. There are just few I would choose to talk about in detail. In telogen effluvium, you're going through stress, you're going through a disease, or you're going through some difficult period, stressful period in your life, and you begin to shed hair. It's usually diffuse. It's not like you're seeing an area that is completely devoid of hair, but you're shedding a lot of hair. It is said that in a day, there should be about 50 to 100 hairs shed is normal. But when we are shedding a lot more than that, particularly maybe about 6 months, 3 to 6 months after the stressful condition, loss, or any other thing, you know that you might be dealing with telogen effluvium. For the anagen effluvium, it's about maybe weeks after the inciting problem. And then we have alopecia areata and androgenetic alopecia, where we have the male androgenetic alopecia and female androgenetic alopecia, and then the trichotillomania, where you're just pulling the hair. It's like a habit. You're reading and you're pulling the hair. So you see quite a number of people, particularly around the margin, losing hair. And then you have the scarring alopecia. They are primarily scarring. You have the central centrifugal cicatricial alopecia, which is the most common scarring alopecia in Black women. It's more common in persons of African descent. Lichen planopilaris, frontal fibrosing alopecia, discoid lupus erythematosus, and the other types of alopecia I have stated there. Now, for traction alopecia, using the framework which I had talked about, you can have, it occurs after chronic mechanical decision from tight hairstyles, braiding, weaves, extensions, dreadlocks, like when we braid our hair, you want it to last for a long time. So you want every single hair follicle to be picked, and that requires tension. For you to get that we always look for, please, Bello Hamida, mute. Thank you. Bello Hamida, please, can you mute? All right, so you can have chronic tension from tight hairstyles. It's usually of gradual onset. It's over time, so you usually find it in middle-aged women, but then the assaults or the insult starts from childhood, where we are making the hair for the child and wanting that child, desiring that child to carry that hair for up to a month, and so you really make it very tight. And then there can be scalp pain, soreness, or burns, which we see. At times, we even see the scales around the areas, and it's usually around the margin. But when it is long, it's gone on for a long time, it can lead to permanent scarring. So what do we look for? We are looking for the marginal type. You have the marginal and the non-marginal type. The marginal is where you have it around the temporal, frontal, and temporal region. Okay, and then there's recession, which is the most common pattern. But for the non-marginal region, some people braid their hair from the vertex. I saw a patient who's a child who always had these braids that started from the vertex, and the child actually had lost hair in that place. The mother, who's a nurse, brought her to me, and when we checked, although she also had some form of seborrheic dermatitis, but when we checked, there was a focal area at the vertex, which was trichoscopy showed evidence of scarring.
Thank you.
Of tension, traction alopecia. Now, you can have broken hairs, and then the prototypical fringe sign, okay, which is a sparse temporal tuft, which I will show in the picture, where the original hairline was, with the continuous scarring, with the continuous tension, if there is loss. And then later, the area that hair is lost becomes smooth. So those are the trichoscopic features: perifollicular cast, reduced hair density, broken hairs, perifollicular white halos, and then the follicular loss of follicular opening as a late sign. So the treatment, diagnosis is usually clinical and with the trichoscopy. Eliminate what is causing it. Change the hairstyles. Do not lose hairstyles. And then the use of minoxidil, intralesional triamcinolone can be used where there is inflammation, because at times the pull on the hair can actually lead to inflammation. And then you can have topical or oral antibiotics. It may end up where it's available to do hair transplantation, particularly when it becomes atrophic. And these are the pictures The first picture is early. The first picture is early. You can see the fringe sign we talked about. And here, this is getting more shiny. And then the fringe sign here. And then this was the child I said had alopecia, traction alopecia, non-marginal from the vertex. Now, alopecia areata, this is of sudden onset. You just suddenly find out, you wake up and then there is a patch that is missing on your hair. And it's usually enigmatic for some people. What could have happened? And we've heard all manner of spiritual connotations given to alopecia areata. There are different types. It could just be focal patches, or it could be the total hair loss, where we call what we call alopecia totalis. It could be the universalis, where you also lose your eyebrows, the hair on the head, all the body hairs, as it were. And psychological stress is said to be a potential trigger. And there's either a personal or family history of some autoimmune disease, thyroid disease, pernicious anemia, vitiligo, or any of those autoimmune diseases. It is said that about 40% of patients can have a history of atopic, allergic rhinitis, asthma, or so. And then you can have the nail pitting and trachonitis. Examination findings, you find well-demarcated oval or round patches, which can be smooth when you touch them. The hair is still, the scalp looks normal. It's just that there's loss of hair. And the pool test can be positive at the active margins of this hair loss. You have the ophiasis type, which is a band of alopecia from the back of the head, the occipitotemporal region. And then I had talked about the trachonitia and nail pitting. Trichoscopic findings, exclamation marks hairs, where you have the top of the hair is bigger than the roots, the bottom of the visible hair. And then you have the black dots where hair is broken, the yellow dots, which is filled with sebum, broken hairs of different lengths, and then the tapering hairs too, which can be coiled, or what we call the pigtails. This can also be found in some other types of alopecia. And for the treatment, we use, it's clinical, diagnosis is usually clinical more often than not, but then there are different causes that can lead to focal hair loss. And you have to be able to rule those ones out. You have your syphilitic alopecia, which is a moth-eaten type, the syphilitic alopecia. You also have the pseudopelade, pseudopelade, and some other kinds of alopecia that are focal. Now, the triamcinolone can be used in a dosage of 5 to 10 milligrams per ml monthly. You can use topical steroids, superpotent steroids like your clobetasol, and then JAK inhibitors such as baricitinib has been used, and particularly in severe and refractive cases. And it's now used in areas where they are easily available. I know we have them in Nigeria now. So, and then contact immunotherapy is another treatment modality. Now, this is the alopecia focal hair loss. And this is the CCFO, where it starts from the vertex, which is the opposite of the ophiasis pattern of hair loss, the occipitotemporal hair loss. And then this is hair loss around the bed area. Androgenetic alopecia can be male or female. The male pattern is the common one. The female pattern is not so common. Anaba did a study in market women in Lagos, and it was just 4.8% amongst the patients we found. It's rarely found in quite a number of studies. And so is it that we are not looking for it, or is it that we ascribe other types of alopecia or we ascribe it to other types of alopecia. But then in many studies, it's not very common. But the male androgenetic alopecia is the common one, which is a progressive frontal recession. There's a positive family history usually, and onset is usually after puberty. Onset before puberty, that's earlier onset, will be more extensive eventually. It is due to increased sensitivity of the hair follicles to dihydrotestosterone, that of the terminal follicles there. And then, but let me just mention here that the occipital hair is often resistant to DHT. And so that's why you have the patterns you usually see where there is balding in the front, all right? Frontal balding, and then, or for some people, the M shape in men, where you have the frontal balding giving the M shape, and then sometimes in the vertex of the hair, and they can join. So, as I said, the occipital hair is maintained. The hair shaft, there's miniaturization. The free testosterone, dihydrotestosterone, causes miniaturization. The hair shaft becomes smaller and smaller, okay, until it completely becomes hypopigmented, short, as you find in the vellus hair. The scalp surface is usually normal with no folliculitis, scarring, and then the pool test is often negative. Trichoscopic findings, we've seen a key feature is increased hair diameter variability, which should be more than 20%. We have reduction in the density of the follicular units, and then miniaturization. Lydia Rudnick actually believes that a follicular ocell with one miniaturized hair and another intermediate or terminal hair is almost always seen in androgenetic alopecia. And then you have the yellow dots in advanced miniaturization. Treatment, we use the 5-alpha reductase inhibitors such as finasteride or dutasteride. Dutasteride has been found to be superior to finasteride. And then your topical minoxidil solution of foam, the oral minoxidil, and then platelet-rich plasma, particularly in the early types. And then you can also do follicular unit extraction or transplant. This is a Norwood type. Sorry. Okay, sorry. So this is the classification, the Norwood-Hamilton pattern of classification. These are patients with alopecia, different types. And then this is a patient who actually, a young guy who came to the clinic. He did not like the fact that he was having baldness and decided to use tattoo, but it didn't go very well. And he came for tattoo, for the removal of the tattoo, which, well, we haven't started doing in Calabar. So I actually sent him, I hope he did go to the place I actually sent him to. Okay. So female androgenetic alopecia, like the male pattern, all right, is not, most times, it is not actually due to, it's not always due to dihydroxytestosterone as is seen in the males. All right, so they've talked about a gene that they've talked about genetics, all right, particularly in the mother. If a mother has it, it's more likely the daughter will have, not the father having baldness, but the mother also presenting with baldness. So it's mostly post-menopausal there's a postmenopausal exacerbation. It's distinguished from, sorry, it should be distinguished from chronic telogen effluvium. And so, sorry, please, just hold on. There's a lot of noise where I'm at. Okay, so please just, okay. So you have diffuse thinning at the crown or the frontal. It's called patterned type of hair loss. All right, so you want to ask for signs of increased androgenism, hyperandrogenism. But like I said, hyperandrogenism is not always the cause of the female pattern. It may be in the male pattern. Okay, so in examination, it could be diffuse thinning at the crown with widening of the central part of the line, preserved frontal hairline, usually unlike in the MAGA. There is reduced hair density and such like. The trichoscopic findings are also similar to what you have in the male, but the vellus and intermediate hairs are greater. There's a greater disparity between that found on the crown and on the occiput. Treatment also, we use minoxidil, topical and oral, and anti-androgens for those that are due to androgens. Some people with PCOS, all right, who may have hirsutism, they may have acne, menstrual irregularities. You want to ask that in the history, okay, might lead you to think that this may be due to DHT. Now, PRP, platelet-rich plasma, treatment with platelet-rich plasma is used, and then the combined oral contraceptive pills, the progestin, low androgen progestin oral contraceptive pills can be used. We can also use the 5-alpha reductase inhibitors. So this is where you can see the hairline preserved. This actually, when we saw, because of the shiny nature, actually we thought it was CCCA, but by the time trichoscopy was done, there was absolutely no scarring, and the hair follicles were intact. There was no follicular dropout, and there were no areas of fibrosis. So the central centrifugal cicatricial alopecia, which is a cause of alopecia in persons of African descent, women of African descent, initially thought to be due to the hair care practice of women, braiding, chemical relaxers, and such like. However, it has been found that a gene, due to discovering them in families, a family history of people with CCCA, it was discovered that a gene, the PAD13, PADI3, sorry, the peptidyl arginine deaminase 3 gene genetic mutation is found in some subsets of people, not all. It may be asymptomatic, there may be pruritus, and it's in some epidemiological studies, it's been found to be associated with uterine fibroid and type 2 diabetes mellitus. Examination, symmetric alopecia centered on the crown. It usually starts from the crown or the vertex and begins to expand outwardly, that's centrifugally. And the presentations may vary. There are some that actually have a patterned look. You will see the frontal hair receding as if you're dealing with androgenetic alopecia. And but on trichoscopy, you notice that you're seeing something completely different. You're seeing follicular dropouts with fibrous areas, pelipila, white halos, and a disruption of the honeycomb appearance. Treatment, discontinue any harmful hair practices. Give your hair a hair holiday, all right? Don't use tight, don't make tight, just like intention alopecia, because it's both genetic and environmental. So you want to help with the environmental aspect. So prevent all those harmful hair care practices. Use super potent topical steroids, then your intralesional steroids and oral antibiotics may actually help. These are patients with CCCA. All right, this was a shiny one. This is from the vertex, the crown of the head. This actually also involved both the frontal and the occipital area. Okay, and this is still CCCA. Now, folliculitis decalvans, this was brought in because quite a number of men are always coming in with this scarring, with problematic. There are some that do not even come in, but they always have this papules and follicles. At times they are bleeding, blood is coming out of my scalp. When I comb my hair is not smooth. So you have recurrent painful folliculitis, which can lead to progressive scarring. This is a scarring type of alopecia. Sorry, the CCCA is a scarring type too. This is a scarring type of alopecia, and it is neutrophilic. CCCA is lymphocytic. It's predominantly found in males. Symptoms: pain, tenderness, pain, pruritus, and discharge, either purulent discharge, pus, or some blood. It has a chronic relapsing cause. It can occur and has some periods of remission, and it may occur on the vertex and the occipital scalp, giving rise to, because it's giving rise to acne keloidalis nocae. They are related. Examination will give you crops of follicular pustules and papules at the active margins, and central atrophy, scarred alopecia with surrounding inflammation. You can have tufted follicles, which we call polytrichia. It's a hallmark of the disease, with about a lot of follicles, greater than 5 hair follicles coming out from one follicular ostia. There could be cross and exudates. Then trichoscopic findings, yes, the tufted follicles can be, well, may be said to be pathognomonic, but it may be found in some other types of hair loss. But it's very common in folliculitis decalvans, peripylar cast, the fibrotic white areas in the burnt out zones. And the treatment is a combination of antibiotics because of its relation, the Staph aureus, which is implicated as a trigger in which the host has an abnormal response. So systemic antibiotics, which in combination is usually used. And we also use topical antibiotics like mupirocin or fusidic acid. Isotretinoin can be used in refractory cases, and intralesional or oral steroids usually helps in very acute inflammatory episodes. Biologics such as the tumor necrotic factor alpha is like etanercept is also used in the treatment. These are images of folliculitis decalvans. And then discoid lupus erythematosus. I say this because I do see quite a lot of these cases in Calabar. And I decided to bring it up because there are people who come in and they're showing you symptoms of certain things. And when you ask them to remove their scalp, for 2 patients, they are quite unwilling until I insist. And then you see scarring, marked scarring. It's because of the lack of self-confidence. It's because of the, the feelings, the negative impact on the quality of health. They really do not want even the doctor to see the scars because it can be really intense. It's insidious onset of patches, okay, of hair loss, and it can be asymptomatic or may cause pain or pruritus. There may be a history of chronic cutaneous lupus in this patient. Usually you find well-demarcated discoid plaques. Active lesions will have erythema. There's follicular plugging because it's a scarring alopecia. It may present with dyspigmentation, where you have central hypopigmentation and a hyperpigmented rim. End stage, you have ivory white atrophic scars. Trichoscopic findings, they are the dilated follicular openings with erythema, and then you have follicular plugging. You have vessels, arborizing vessels, and in the perilesional margins, and the white scales, keratotic white scales. Treatments, sun protection is important because it can be a trigger. Hydroxychloroquine, potent steroids, and intralesional steroids. Thalidomide has been used, and then some biologics are also used as seen here. Now, these are types of therapy, but these patients were patients with SLE, systemic lupus erythematosus. Okay, so comparative trichoscopic findings at a glance. Condition, traction alopecia. Is it scarring? No, the early one is not. Key findings, empty follicles, peripylar white halos, and the CAS. And pathognomonic sign is the fringe sign most times. You can have pseudo-fringe sign in pseudopelade, but that's a scarring alopecia. Alopecia areata, is it scarring? No. Yellow dots, if you can find the exclamation hair sign and black dots, and so you have exclamation signs being said to be pathognomonic. Androgenetic alopecia, there's a hair diameter variability greater than 20%, and you might have the peripylar sign, which can be gray, it can be white, it can be gray, or it can be white, or it can be brown. CCCA, you have may present with tufted hair. Remember, I said folliculitis decalvans is where you have tufted hair, but it's been found in some cases of CCCA, and then you have follicular dropout. Hair is not growing anymore. The peripylar white halos, and then your folliculitis decalvans, and in the DLE, the keratotic plugs with follicular red dots, and the plugging is almost significantly there. So, traction alopecia, these are some pills that you can take with you. The fringe sign, CCCA, is under-recognized, but it is very common. And then we have the alopecia areata with your yellow dots, exclamation signs. These are things I've talked about. Okay, so the key takeaways: alopecia is a common debilitating disorder that can negatively impact quality of life. Patients with African hair often have more than one type of alopecia at a given time, so the clinician has to be mindful of that. It involves an interplay of the genes, the hair fragility in the African hair, and then harmful hair care practices, the tied braids and other twists and turns of the African hair, of hair braiding. And then the dermatologists are trained to manage hair loss. Early detection and intervention can actually stop the progression of the hair loss. It might not be able to reverse a scarred area, but it will definitely stop the progression. Because if progression is not stopped, this is the early form of a disease, and this is where it ends. This is something nobody wants to grapple with. Time is hair follicle. Trichoscopy is an invaluable tool. The dermatologist is trained to determine the type of hair, differentiate types of hair using the trichoscopy. Sometimes we do biopsy, particularly in DLE and where we are not certain. Consultation is incomplete without patient education. The latter is integral to compliance because the patient will actually cooperate with you in ensuring that she has a desirable outcome. Well, these are my references. Thank you very much for listening.
Thank you very much, Ma.
Over to you, Howard.
Thank you very much, Ma, for your beautiful presentation. We all learned from this. So I will give a summary of the major points. Prof mentioned she gave a definition of hair loss as alopecia, and she gave the common causes of hair loss in this environment. What of note is that the black hair is kinky and oily, so it's a lot of practices that can cause hair loss. and that hair loss also affects the quality of life of patients. And some patients may present with more than one type of hair loss. She emphasized that prompt intervention by dermatologists is very important because time is hair follicle. Then she gave an overview of the hair biology, and then she mentioned of note is that the adult hair cycle is complete. So that means we should try as much as possible not to prevent hair loss in adulthood because the hair cycle is already complete. Then the hair cycle is made of the anagen, telogen, and the catagen phase. She mentioned the different functions of hair. Then she gave specific examples of the different hair losses and the most common types. Then in evaluation, that is history taken in a patient with hair loss, she mentioned that the onset is important, duration, the pattern of hair loss, that's where the hair loss started from, family history, the hairstyling practices, chemical use, medications, diet, and systemic illnesses. Then important investigations in hair loss include measurement of serum ferritin, zinc, vitamin D, and thyroid panel. So then she mentioned the traction alopecia, as one of the most common type we see in this environment. So the typical thing that is seen is that honeycomb pattern and the white dots are normal in African hair. So during trichoscopy. So, but for traction alopecia, you have the hair cast, peripylar halos, the follicular units are reduced. You have some empty follicles, and the fringe sign is very important in traction alopecia. And so she also mentioned the management. Then she also mentioned alopecia areata, where you have exclamation mark hair, white dots, and yellow dots. And treatment includes minoxidil, triamcinolone, JAK inhibitors, and platelet-rich plasma, which is in use in so many places now. Then the androgenetic, she mentioned androgenetic alopecia and female pattern hair loss. Then central cicatricial centrifugal alopecia, though not common, but it's a form of scarring alopecia and is seen in some environments where patients present with pruritus, tenderness, and may be associated with fibroid and type 2 DM. So the scalp is usually very shiny, and this is to differentiate it from the female pattern hair loss, which is non-scarring. So the scalp is the central centrifugal alopecia is scarring. So trichoscopy shows empty follicles. Then the folliculitis decalvus, that is a form of neutrophilic hair loss. So patients present with pain and pruritus is more common in males. Some may have tufted hair follicles, and the hair loss is usually from the vertex and occipital region. Gold standard in treatment is rifampicin and clindamycin, but although acetretinol can also be used. Then the discoid lupus erythematosus, this is usually associated with SLE. So most times treatment will be with the rheumatologist, but hydroxychloroquine is also important in the use here. Then take-home messages is we should take care of our hair. Then trichoscopy is very important in evaluating of hair loss. We hardly do scalp biopsies, but trichoscopy is important in the evaluation of hair loss. Thank you. So we entertain questions from online and basic. Okay, Ma, just a question here. Thank you, Ma, for your excellent presentation. Beautiful presentation. What are your comments on continuous use of wigs with tight hair bands and hair loss?
Okay, that's a good one. Now, we just had a patient we did trichoscopy for, and we could see a patient who was using a wig. I don't know how often she was using the wig. Oh, no, we asked. Because of the hair loss she had, she was always using a wig. Hair loss, there's something called the pressure. That's constant, intense pressure. Is almost similar or can give you what you may have with tension. Because pressure actually constant pressure causes friction, and you can have inflammation. From trichoscopy, we could see the erythematous band in a dark-skinned person. Erythematous band, with some hair, absent hair follicles, not clogged. But yes, you can actually, the use of tight wigs can actually lead to hair loss if it's chronic. In fact, I remember in the clinic that day, the residents were asking me, they talked about some people who were always using wigs, and they said, oh, they wonder what they will find. Some of our colleagues who are forever using wigs, they wonder what they will find at the band. So yes, using tight wigs can also lead to hair loss. Chronic use of tight wigs with band can also lead to hair loss. So you may want to loosen the band some, okay? And now and again, you can use other forms of hair covering or hair holidays. You can give yourself other forms of hair holidays, not just the wig. Do I have another question?
Yes, ma'am. Yes, ma'am. Thank you, ma'am. I would like to ask about the role of PRP in hair loss, platelet-rich plasma in hair loss.
Oh, that's the new kid on the block for some of us, and it's been shown to do in alopecia areata, in androgenetic alopecia. It's been shown to be helpful. I think Dr. Otrofanowe, presented something like that, and quite a number of us got, took it up from there, and it's actually something we should try. I know of somebody who now uses PRP. She's gotten more success with PRP compared to the steroids, intralesional steroids, and the side effects are not as bad as you would have. The side effect profile for PRP is much less than what you have with intralesional steroids. So I encourage the use of it, particularly in this, not in this scarring type of alopecia, please.
Okay, thank you, Ma. And Dr. Zainab, if you have experience with using PRP, maybe you can share it here. Ma, another question. What is your experience with the management of trichotillomania in your practice?
Well, most times, like he said, it's a habit that is formed, and there's some psychological leanings with trichotillomania. And most of the time, we want to send them that after discussing with them and telling them without breaking that habit, that hair loss will continue. It's very difficult. So sometimes we need psychotherapy, and the patient often will be helped by the psychiatrist. But this must be discussed with the patient, so the patient does not think, oh, they are saying I have a mental health disorder, but there's some psychological leanings when it comes to trichotillomania. So it's managed in conjunction with the psychiatrist. Yeah, you can use minoxidil. You can use anything that will help prolong anagen growth or instigate hair growth is welcome in them. Okay, so, but please manage in conjunction with the psychiatrist.
Okay, Ma, another question here. Okay. What is your experience with DPCP? We used it before and PRP several years back, but we lost the 2 patients to follow up. So just ask the experience with DPCP.
The truth about it is it's supposed to, well, I've not used DPCP. I've not used the contact immunotherapy, all right? So I wouldn't say I've got experience with that. But it's supposed to trigger some form of inflammation. That's a managed inflammation that actually helps the hair. For some, they say it works, but I can't really comment on that because I've not used it for my patients with alopecia areata.
Okay, Ma. Any input? There's no question in the chat box. No more question. So do we have anything for any announcements from the president?